Dear colleagues, I'm Filippo, Crea, Editor-in-Chief of the European Heart Journal. Welcome to our monthly EHJ Dialogue. I remind you that the dialogues are Socratic conversations among authors, editors, and readers. They are free and live streamed. So please ask questions and we will answer your questions. And do not forget to subscribe to our YouTube channel. And today it is really my privilege, my pleasure to ask Colin Berry, who is executive editor of the European Heart Journal, to present our guest for today. Today, we have a very important guest. He is one of the fathers of interventional cardiology in Europe, and not just in Europe. We have with us Patrick Serruys, and the title of this dialogue will be Interventional Cardiology from Device Design to Clinical Success, a journey in the past 40 years, a journey which will be illustrated by one of the protagonists in this field in the last 40 years. Colin, please, can you present Patrick Serruys?
Patrick, Professor Serruys, it is a real privilege to introduce you to the European Heart Journal Dialogues. You are the leader in the field in interventional cardiology and have been for, if I may say, over 40 years. You have been a leader and a teacher for so many fellows, mentors, who themselves are now established as leaders in the field. So it's a great privilege to have you join us today. Perhaps you would like to say just a few words about reflecting on your career from the start and indeed to where you are at this moment in time. And then having heard that, we can then move into discussion to ask about some particular questions. And just as I pass over to you, Patrick, I'd like to welcome everyone who has made time in their no doubt busy days to join this dialogue session today. Thank you for being with us, and I do hope that you will find this edifying and insightful. Patrick.
Yeah, I mean, it's an interesting misunderstanding. I thought that you were going to present me. I mean, you obviously asked me to say a few words about myself, which is always very difficult. In short, I was educated in internal medicine in Belgium, in Leuven. I didn't go to the United States because I was attracted by my mentor, Paul Huguenots in Rotterdam, in Erasmus University. I made indeed a very long career in the Erasmus University as a professor of interventional cardiology and then professor of medicine. I retired officially in 2012, did a little bit more until 2014. And then I joined the Imperial College, and then a little bit more than 1 year ago, I was attracted by the invitation of William Waynes to join him in Galway. That's a kind of fatal attraction, so I could not resist that fatal attraction. And I decided to join, and I really enjoyed my time here. We moved with a larger team of people, I think up to 12. And we have now in the core of the university and the hospital with a lot of new activity among my Irish friends. And I'm very grateful for the way they support us here in Ireland. So, enough, Colin.
So thank you for that reflection. So I've had the privilege of having sight of your CV, and I mean, it's stunning, Patrick. But perhaps just for the audience, I could reflect on some details. Of course, there are so many interesting aspects of your career. So first of all, the work that you did in Leuven at the start of your career, preclinical research with Sir Alan Hodgkin, a Nobel Prize winner. And this work was bench research as a student, voltage patch clamp, fundamental myocardial biology. I think many of us who have joined this have personal experience of science, but is there anything that you would like to share with us from that experience that you had?
Oh, yeah, that was a wonderful time in Plymouth. I discovered the chip and chips, you know, that's point number one. And then Alan Hodgkin Nobel Prize, a very simple and modest individual. So in the morning we were fishing what we call the cuttlefish, you know. You remember in your textbook the giant axon of the cuttlefish. And then in the afternoon, we were pushing the microelectrode to measure the potassium and sodium current. And it was amazing how this great man was nice. So at the end of this summertime in Plymouth, we went to the pub to have a drink with Sir Alan. And then my colleague, we were three of us said, can you ask him what he did with the money of the Nobel Prize? And I found that quite personal, but finally with the help of the alcohol and the pub, and I said, Sir Alan, what did you do with the money of Nobel Prize? I said, it's not my question, it's a question of my friends. And he said, oh, I purchased a central warming system for the house. Yeah, and that was his answer. So that tell you all about the man, yeah.
So in a career of science and clinical science, I do think that diversity of experience is so important because it positions you to be able to take different perspectives on a particular problem. So when we think of Patrick Serruys, we think of stents and interventional cardiology, of course, through and through, but it's interesting that in your career, you also have this science, diversity of science, where you've undertaken fundamental studies at the laboratory bench, in this case in patch clamp and mechanical coupling of the muscle. But of course, those experiences in basic science can then be applied to bioengineering when you've been involved later in your career in the development of so many different stents. I wonder if you'd like to share some words about your clinical training, because after you completed your doctoral thesis in Leuven, it then seems from your CV that you really focused on clinical training in cardiology. And I wonder if you could share some words about some of your own clinical mentors in those years in Belgium.
Yeah, in Belgium, I spent a lot of time in the laboratory of Aubert in basing on the muscle mechanics. And I worked there. He sent me to Plymouth to work with Sir Alan. But I quit with the physiology lab around the third year. And it's interesting because Professor Aubert was so universal. You know, he was a physician, of course. He has a great sense of mechanics. He was building up his own strain gauge. He has at that time a tremendous knowledge of statistics. So at a certain point, I said I will never be able to do that. And I quit with the lab. I did some study on creatine kinase in the sartorius muscle, etc., etc. But of course, what happens is that I translate this knowledge of the muscle, experimental analysis of muscle to cardiology. That was a kind of sublimation of the field, yeah. But that's certainly somebody who has impressed me very much, yeah. Then I moved to Rotterdam, which was the mecca of the computer in cardiology. Everything was computerized. I had a hard time to learn the Fortran language, which was the only language for computer at that time. And immediately I connect with the engineer. I mean, I like that. And the first things that I spent a lot of time was developing the quantitative and geography, which was really something very important, 76, 7, and 8. And then it became a useful instrument. And of course, my mentor was polygonals. Who doesn't know polygonals? I mean, that was a giant. Nothing was impossible. And I think that's probably the individual which has given me self-confidence. I mean, that's the person, nothing was impossible. And that was a good motto in life, yeah.
And before going into cardiology, or were you influenced by thinking in other specialties? Did you always, you know, from your first breathing moment, was it going to be cardiology and interventional cardiology, or in the rotations that you had through pulmonary medicine and hematology and intensive care, which I can, you know, see where you've been?
No, not at all. You know, like probably like Filippo, we have been educated with 6 years of Greek and Latin, okay? And when I had finished that cycle, my dream was to become a philosopher, pure philosophy. So I wrote a letter to my father in Belgian Congo, and I said, I want to go to Leuven to study pure philosophy. And he said, that's a good idea, but you know, Socrates, we have Socratic dialogue. Socrates in the 20th century will not bring bread to the table. So you're a good student, do something else. I don't mind lawyer, engineer, medicine, whatever. And then I said, okay, I'll do philosophy and medicine. And maybe after that, I will become a psychiatrist and combine all these things together. And then I was very existentialist at that age, 17. And what happens is that the first years of philosophy, I passed the exam in early June and the medicine in August, but it was terrible. I mean, it was all memory, it was boring, etc. And then I abandoned the philosophy and joined the lab of physiology and fell in love with physiology. So that's it.
So I had restricted my thinking to your medical career, but I'm now wondering if I may, and perhaps others are also interested in where you were brought up. If your father, you mentioned, was in the Belgian Congo.
Yeah, I mean, it's in the Belgian Congo from my birth, basically. And I stayed there for 13 years. And there is a famous pictures which has been published, I think, 2 times in the circulation, where you could see me as a kid on top of hippopotamus. I mean, there was a very special animals. He was every Saturday coming out of the water. And then the owner of the house said to my father, if you give him a bottle of vermouth, you know, red martini, the animal will fall in coma because they don't have the appropriate enzyme to metabolize alcohol. And then you could go on his back, open the mouth, etc. Today, it's the most dangerous animal. And to give alcohol to an animal is certainly not politically correct 70 years later, yeah, or 65 years later. But it was a wonderful time of liberty and larger space. I mean, you know, Africa, it's a wonderful continent.
So coming back to cardiology, thank you for these insights into your upbringing and your background. At what moment did you decide that you were going to be an interventional cardiologist?
A little bit by accident. I mean, clearly, you know, we have a background of internal medicine. So basically our job was to make diagnosis in internal medicine. and then diagnosis in cardiology, which is basically catheterization and finding what is not working in the heart. So we did that. I mean, I started that in 75, 76, and suddenly we heard about Andreas Grünzig. You know Andreas Grünzig, I met him the first time in Frankfurt in 1974. He was an obscure East Germany, because he was coming from East Germany, radiologist with a poster on opening the coronary artery of the dogs that he had ligated with a catgut, you know. And in the main auditorium, you had Paul Lichlen, which was our German Braunwald of medicine, saying, look, this guy is doing. And the same moment he was presenting what we will call today a vulnerable plaque, you know. And so I went to see that Andreas Grünzig, and I found fantastic what he was doing, because it was the way to induce ischemia without opening the heart. You can put the balloon in the coronary artery on a closed chest, closed. So I was obsessed by the model for wall motion abnormality, and he said, no, I intend to dilate. So suddenly 3 years later, he's doing the first patient, and by the time of the third course, of course, we were all there. I was 30 years old, and then, yeah, you know, we start to do these things. So simple. I mean, the motto at that time was, you see one, you do one on your mother-in-law, you do one on yourself, and you do on the patient. Basically, we had no mentor, no proctor, nothing, just going one time to the course in Zurich for 3 days. And then we had to start. Today, everybody has a proctor to facilitate that. So that was a very exciting time. And the fact that suddenly you became an operator, you know, a mini surgeon. I mean, that was something fantastic to open a coronary artery in a few seconds, to open a thrombosed artery. Yeah, that was a real ecstasy, I would say. Yeah.
And you've led this incredible journey in interventional cardiology from those first moments with Andreas Grünzig through balloon angioplasty to the development of coronary stents, the development of coronary stents with drug coatings in their different forms, and then more recently to the development of bioresorbable scaffolds. And your contribution is extended beyond implantable devices to intravascular imaging. I wonder if you might share some thoughts about the developments of intravascular imaging that you've observed over the years.
Yeah, the intravascular imaging, I mean, we were fortunate to have in Rotterdam Klaas Bohm. Klaas Bohm was a great physicist. I mean, initially he was chasing with Doppler Russian submarine in the Mediterranean, believe me or not. Polygonals found him, and he started to introduce ultrasound in Rotterdam. So basically, we were the very first to have an ultrasound catheter. First, we started in the femoral, and then we went to the coronary artery. And having that tradition of intravascular imaging, we never stopped. So there was, after that, the OCT, and after that, the near infrared. But it was a long tradition, starting in 1986. 1986 is one of the first papers on intravascular imaging. You have Paul Yock in United States, who was doing something quite similar, but it was a very exciting time, yeah.
Thank you for that. So what I'm doing just now, Patrick, is walking the audience through your career, and then we'll come to some more specific questions and include to take questions from those who are online. So you were the the chairman and director of service at the Department of Cardiology in Erasmus Medical Center, and you were there, I believe, as head of service for 14 years. Is that clear? You were there for longer, but you were head of service for 14 years. Is that
Yeah,
correct?
I mean, I started in 76 and I left in 2012, 2014. Yeah.
And what would you say are, the proudest moments from your time as the head of service in the Thorax Centre? If you look back and think, that really was a great achievement. And of course, your perspective may be different to what others might think. What were the special moments for you as you led that world famous cardiology centre?
Yeah, I think people have forgot that, but we were the generation who start with the streptokinase IC, streptokinase intracoronary artery. So we invited Winthrop, and then we start at the Thorax Center. And I will never forget the emotion of somebody having an ST elevation, suffering, being anxious, sweating, and so. And then you were dropping the streptokinase in the coronary artery, and at a certain moment, the vessel was coming back, the pain was leaving the patient. That was a very emotional moment from the therapeutic point of view. Then there was the moment where I was planning to go to Iowa to work with Melvin Marcus. I had already signed document and so, but then Paul convinced me to stay. Of course, I became professor at quite a young age, and then in charge of the interventional department for more than 20 years. But the difficult achievement, an important achievement, was the introduction of the stent, that's for sure, yeah. In 91, I report the experience of Sigwart, Tony Ricards, Balcon, Michel Bertrand, and it was a very sobering experience. I mean, there was a lot of acute thrombose, late occlusion, restenosis. But I report that honestly in the New England in 91, and that was a piece of, I established somewhat my credibility in the field by reporting bad things. My friend Peter Block at that time made an editorial which was quite devastating for the stent. He said they worked for a long time on the device, but it looks like the mating of two elephants. It happens on a very high level. There is a lot of trumpeting, but nothing comes out. And it's true that there was a lot of noise about the stenting, but the result was pitiful. And the pregnancy of an elephant is indeed 2 years. So I felt a little bit guilty to almost kill the technology. I was reporting the first 102 patients in the literature, thanks to Tony Ricards and Ulrich Sigwart. And then I tried to rebuild the experience of the stent, and that's the Bene stent published in the New England also in 94. And that was a very rewarding experience. So we went to Washington in April 94, and there was a public panel of the FDA. We present the technology, and although the technology has been turned down by the FDA 5 times in a row, at that time the technology was presented by his inventor, Palmas, Julio Palmas and Schatz, and by presenting the Bene stent and the stress, we get approved on the same day. And that was a major achievement. And we may say what we want about stenting, but it had helped a lot of patients in the world. And then, of course, we create the iatrogenic disease, which was the neointimal hyperplasia inside the stent. But I was fortunate that in 97, Elizabeth Nabel told me, you know, if you can upregulate P27, the neointimal hyperplasia will disappear. And I was quite skeptical, you know, so many people have single out one molecule who could make the tricks, but nevertheless, I explored that with Cordis, and then in the summer 99, we planned a first in men, in 15 patients in Rotterdam and 30 in Sao Paulo with a pioneer of the bare metal stent, Eduardo Souza. And then, that was quite amazing because I was leaving Amsterdam in the evening. I was in the lab the next morning at 7 o'clock because the plane was arriving at 5 in the lab. And then also for the control, there was 15 patients in the row in Sao Paulo. We were a little bit slow in Rotterdam. And then it was fascinating because one patient after the other was coming very clean. I mean, it looks like if you have implanted the stent in the morning. I remember Eduardo Souza at some point, we had done 27 patient, controlled 27 patient, and then there was a lady diabetic with some chest pain, and Eduardo told me, this lady has reached the nose, and he put $100 on the table as a joke, and there was nothing. I mean, that was phenomenal. And of course, in that year, in the year 2000, I had the lectures, the Grunzig lectures at the ESC, and I present the first 33 cases with follow-up out of the 45, and no restenosis, no late lumen loss, nothing. And then there is this famous quotation that everybody use and misuse when I said, don't wake me up, let me dream, don't pinch me, etc., etc. But the dream became true.
Absolutely. So if I can bring this journey together just to give a sense of some of the achievements to those who are with us. You have 3,500 scientific publications, 170,000 citations since 1975, 20 publications in the New England Journal of Medicine, 3 in JAMA, 33 in the Lancet. You've been an editor of 45 books or textbooks, including, importantly, the ESC textbook of cardiovascular medicine. For the fellows who are with us today, Professor Serruys has supervised and delivered over 90 PhD theses and given over 1,400 invited lectures in the last decade. This is an incredible, incredible achievement, and I want to congratulate you in everything that you have achieved in your career. So many people have been educated by you, and so many patients have benefited. Looking more widely beyond the thorax center in your professional practice, you've also made significant contributions to stakeholder organizations. And I'm thinking of the EuroPCR, the ESC, TCT, and some of the other international societies. But perhaps I could just ask you about your role in EuroPCR.
Oh yeah, EuroPCR, you know, in just after the publication, the New England in '94, I decided to have a stent course in Rotterdam, and it was very successful. I mean, we had 1,500 seats in the main auditorium of the university, and it was full. And, you know, all the people, Eric Topol, Binol Neal, everybody was there because United States has no access to the stent, and we had access to the stent. And that course was very successful until the year 2000. It was very successful, but it was uneasy for me to have one course in Toulouse and Paris and another course in Rotterdam. So I met Jean-Marco and I said, why we don't unite these two things and have one course? And that became, my course was Euro-CVS, Euro-Cardiovascular, and his course was PCR, Paris Congress of Revascularization, something like that. And it became Euro-PCR. And that was one of the best things that we have done in our career, is to merge these two courses. Yeah. And then, of course, we create many other things like Euro Intervention. In 2004, I said, look, we have a lot of communication, verbal communication with the audience, but we don't put anything in writing. It's very important that there is a written message to the community, and that was the start of the Euro Intervention, which has an important role today in Europe, but also worldwide.
Absolutely. And this
Colin,
is
Colin,
yes.
can I ask some questions to
Please.
Patrick as well? It's been really a wonderful story so far through your life. Now I'd like to ask you some questions about the present and the future for our audience. When you said, don't wake me up with zero restenosis, now we know that it was not zero restenosis with drug-eluting stents. And in spite of the extraordinary success in this field, the rate of restenosis and in-stent thrombosis is definitely lower than before with first, second, and third generation drug-eluting stents, but is still more than zero. In your crystal ball, do you think that in the future we will reach zero restenosis and zero in-stent thrombosis? And what is the path to go towards this remarkable result?
Yeah, it's a very complex question. I think that today, if you look at all these studies, the rate of restenosis and thrombose is becoming very low. It's become very difficult to make a trial because we are in the range of 5%, 0.5% thrombose. It's not zero, but it's so low that it's become difficult. You know, all these Me Too trial is in the range of 5% of MACE. So I'm not obsessed anymore by the restenosis and the thrombose. I'm more obsessed in clinical practice by two things: is the fact that 20% of patients after a successful procedure, of so-called successful procedure, still have angina. That's one problem. The second problem is that with the thickness of the struts becoming less than of around 60 micron, the stent thrombose is maybe not the target anymore, but I'm afraid that the bleeding is one issue that we face more and more in our practice. So as you know, with the global leaders and the asset, I have tried to eliminate an old friend, which is the aspirin, which is non-specific, non-potent, became an antiplatelet by accident, I would say. So I think bleeding is an issue. I think that we are basically today over-treating the patient with dual antiplatelet therapy and creating bleeding. And if you see result of study like Twilight, Global Leader, TICO, it's clear that we can afford to reduce the aspirin. There is now 18 trials with reduction of the dual antiplatelet therapy. And we have done the first trial published in JACC Intervention on no aspirin at all. Okay, that's the ASSET trial for acetyl salicylic elimination trial. And we are continuing in that direction. In 2013, when I proposed to my friend Stefan Windecker to try to eliminate the aspirin, there was a tolly. They said, you cannot do that. And finally, we compromised on 1 month of aspirin. But I think it works. I think that aspirin has been a long friend for a long time, but that's point. The second point is the 20% residual angina. And that's a serial issue because clearly with William Waynes, Bernard de Bruyn, and Nico Pels, the introduction of physiology in interventional cardiology has been very important, has gained ground all the time. It's clear today that we can make the difference between the ductile conductance, the conductance of the epicardial vessel and the microvasculature. We are discovering that not all lesion has to be treated. That has been a very important message. The problem is that we still need a piece of hardware. I mean, a pressure wire, which is not the best wire of the world. So I think that the last few years, the fact that we got QFR, which is kind of FFR derived from conventional cine angiography, and you will see very soon IMR from the conventional angiography. It's not maybe as good as the pressure wire, but the Bayesian meta-analysis that we have done and published in the European Heart Journal 2 years ago shows that it's very close. So I think that we are going to see more and more practical physiology in the cath lab derived from the conventional cine angiography. And then we are going to realize that more and more that there is a problem of microvasculature, which can be structural, which can be functional. And unfortunately, we have no drug for that kind of patient. I mean, and some of the structural coming from diabetes cannot be reversed easily.
Yeah, of course, Patrick, with Colin, we fully agree with you that functional alterations of coronary circulation is an important topic, and we don't have really drugs addressing these alterations. I have a question from looking again to the future from a colleague from China, Dr. Mengmei Li, is asking about in the future radiation-free cath labs. Do you think this is something in the pipeline?
Yeah, I think that there is two aspects. I think that I strongly believe that in the first place, the concept of cath lab with the conventional cine angiography, I will shock you, will disappear. I think that conventional cine angiography in the next decade will disappear. And I say that bluntly, but I believe in it because the non-invasive imaging, mainly the multi-slide CT scan, but at some point the MRI will make its entry in the clinical arena. The multi-slide CT scan is really providing us with image of quality and with the FFR CT. So there is the anatomic and functional component. We published in the European Heart Journal the syntax 3, which was we were not randomizing the patient, we were randomizing the doctor. We were getting a concordance between two decision-making, one by the based on multi-slide CT scan, the other based on conventional cine angiography. So I was already convinced 2 years ago that the decision-making to go to surgery, to go to PCI, or to have a pharmacological treatment could be made on a multi-slide CT scan. And now we are one step further in a trial called Fast Track CABG, where the surgeon is operating 3-vessel disease and main stem with only the pictures of the multi-slide CT scan, is unaware of the cine angiography, and it works quite well. So if the surgeon can treat the top of the pyramid, which is 3-vessel disease, calcify, and main stem, then we interventional cardiologists can of course treat the 1- and 2-vessel disease. And I will go in the lab, which is now an interventional suite, knowing exactly what I have seen, the amount of calcium, where are the lesions, in which projection I should work. So to respond to your Chinese friend, I think that we are going to see more and more multi-slice CT scan. Don't forget that with 1 millisievert, 1.5 millisievert, you can get all this information, while your characterization in the best lab is still 8, 9, 10, 12, sometimes more. So that part is going to be the job of the multi-slice CT scan. And the conventional catheterization lab is going to become an interventional suite. Now, the question is the complexity of the procedure. You know, when you do a cardio band, when you do a total occlusion, when you do a bifurcation, that's where I'm very much concerned, because there the radiation is increasing and increasing mainly for the operator, for the practitioner. And so far we have no alternative at the horizon. The fluoroscopy as a roadmap system is still very, very important. So I'm afraid I don't have a Chinese colleague. The only thing is that you could prepare the intervention much better. That certainly. You don't have to be in the lab shooting 2, 3, 4, 5, 6, 10 view and then say, no, I'm going to take ad hoc decision to make, now that time is over, I think.
Patrick, thank you for your wisdom. Moving from China to Europe, we have a question from Madrid. Dr. Brugaletta is asking about the heart team. You introduced the heart team with the syntax trial, at least in the cardiovascular field. What are your feelings about the heart team after these years?
That's a very good question. I mean, I must say that when I arrived at the Thorax Center, the heart team was already there. I mean, you know, Polygonals, when he came back from Boston, decided to make a real association with the surgeon. So that's the name Thorax Center, 3 components: the surgeon, the cardiologist, and the engineer. And that has always been there. We had the heart team from 1976. It's true that with Frederick Moore, when Frederick Moore said very adamantly, I don't want to do a trial, interventional cardiology versus surgery with a cherry picking of the patient, with a selection. Everybody has to be in the trial, either in a nested registry or in the randomized. Then there was a real need to discuss the case before. And I was very lucky, because at one point I said, okay, how can I force the surgeon and the interventional cardiologist to look very carefully to the cinefilm? And that's the syntax score anatomy, but that's 2005. In the meantime, it has become mixtures of anatomy and comorbidity and functionality. So I think that the art teams is very important. And when the valve came, it was even more important, because you had a surgeon, you had the interventional cardiologist, but you have also the expert in elderly, you have also the whole echocardiographyist and so. So I think that the heart team is very, very important, has to stay. Now, we have published last year in the Lancet the Syntax 2020. I must say that I'm pretty pleased by this score. You know, first, it has, of course, been derived from 10 years of the syntax study. You can say, okay, that's old-fashioned, outdated, etc. But then with Valentin first, we validate on the freedom, the pre-combat, also the Excel, by the way, it's in a letter to the Lancet, not in the original publication, but syntax, freedom, pre-combat was the 3 trial. And then very recently with my friend Takeshi Kimura in Japan, you have there this huge registry Credo Kyoto, surgery and PCI. And there is 3 cohorts, and each cohort is very different. And the last cohort, the cohort 3, we are testing again the syntax 2020. And I'm pleased by the prediction. So we go progressively to what I call for precision medicine. You should realize that we, clinicians, but also trialists, when we are looking at a trial, we look at the average treatment effect. You know, the 2 Kaplan-Meier are diverging. One treatment is good, the other treatment is bad. In a kind of binary judgment. That's not the way it is. I mean, clearly there is an unbelievable heterogeneity of treatment effect in the randomized population. There is case which will be harmed by PCI, other will benefit of PCI, and other with equipoise, even in vital prognosis, PCI bypass surgery, and vice versa. There are surgical cases where you can harm the patient. There are, of course, surgical cases, great benefit for the patient, and there is equipoise. So we really need to have these individualized, personalized medicine. That's point number 1. We need some mathematical support. I mean, after all, there is so much machine learning, etc., etc. But the contact between doctors in the heart team remain, of course, the core of the judgment. Yeah.
Well, teamwork is important not only in cardiology, but during our daily life. And thank you also for addressing the issue of personalized medicine, because this was one of the questions asked by Dr. Baumik, one of our colleagues in the audience. Now, I'm sure that Colin has got some more questions for you for this fascinating conversation. Please, Colin.
Yeah, absolutely. Chronic total occlusions. A controversial topic, at least for some, but for others, an area of fantastic technical developments, creating treatment possibilities for patients that could never have been imagined in years gone by. You've obviously been very involved in this aspect of interventional cardiology. I wonder if you could share your thoughts about how the practice of CTO will evolve technically and also a wider level for patients.
Yeah, thank you for this question. You know, first, my modest contribution to the field, you will not believe it, is that I work on the laser wire. Maybe you remember the laser wire. We published that in the European Heart Journal in a trial called Total. That was wonderful. There was a small guide wire with the laser at the tip. If you read carefully the paper, 27% of the case we went outside the coronary artery without consequence, because there was so pinpoint laser activity that there was no catastrophe. But what I developed at that time is bilateral coronary angiography. So the first time I said to my nurse, today we are going to have 2 catheters and inject simultaneously the right and the left, she always threw me out from the cath lab, and we have been working 15 years together. But I think that was very important to have the right and left simultaneously. Now, what can we say about the CTO? First, it has been there for a long time, and it's clear that the proximal total occlusion LED completely filled by generous collateral of the right coronary artery with viable collateralized myocardium with almost normal wall motion and showing ischemia in more than 10, 15, 20% of the ventricle. That's clear that that lesion, if it can be recanalized, should be recanalized. But forget the hypoplastic posterior descending artery lying in an akinetic inferior wall without viable tissue. That should be forgotten. Having said that, despite all these years of practice and accumulated experience, there are only 2 a specific trial in CTO, Euro-CTO, published in the European Heart Journal, and Decision CTO. And it's still miserable. I mean, Euro-CTO randomized 296 patients, 2-to-1, 12 months MACE, no difference in MACE. MACE was comparable at 12 months. Freedom of angina, if I remember, 71% for PCI and 58% for medical treatment, with a p-value, we all agree. Seattle Angina Questionnaire and quality of life was also significantly better in the PCI. The second trial is Decision CTO. That's the most robust trial. I think 834 patients or something like that. But again, at 4 years, no difference in primary endpoint in the classic MACE, 22% in both groups. But both group has also significant improvement in health status. I mean, but without in-between difference. So it is a difficult fact. The last piece of information which has been published in JAC this month is we have looked in the syntax, 10 years mortality, what was the difference between a failed CTO, successful CTO, or CTO not attempt. Colin, I'm sorry to disappoint you, but no difference in mortality. So that's a little bit sobering. I still believe that when you have a high volume chronic CTO PCI center, people who knows what they do, recanalization should be primarily offered to patients for the management of angina, refractory medical therapy, when myocardial viability is demonstrated. That's the key.
Okay. So we are probably got a limited amount of time left. So I'll maybe ask one more question and then pass over to Filippo. If he permits me, I'll ask more, but I'm not sure our time will permit.
Well, why not?
Okay, so what would be your suggestions for the young colleagues to achieve success in their career as they set out? What would be the key things that they should hold on to and the key things that they maybe should not do?
Yeah, I had the extraordinary privilege, and you mentioned, to mentor 94 PhD in 33 years of professorship at the Erasmus University and also at the University of Amsterdam. And I've trained about 200 people in interventional cardiologists. We just lost David Foley. I mean, that was one of my favorites. He spent 6 years with me. William Waynes was one of my first trainees in 1982. We were just 2 years of balloon angioplasty at that time, and you know his exceptional career. But the success of a career remained, from my point of view, unpredictable, at least at the time of the initial interview of the candidate. I did interview many candidates, and I have to conclude that the future of a candidate is unpredictable. I'm very modest on that. Probably I'm a bad psychologist, but I could not say that guy is going to make it and that guy will be a failure. There were people coming to me with zero publication and became so prolific. I mean, take Carlo Di Mario, take many people who have been in the lab. I think the three basic conditions of success is well known. You have to be reasonably intelligent, but we are all reasonably intelligent, believe me. Work hard, there is no doubt about that. But what is very important is a good psychosocial behavior. That's very important. I've seen very smart guys being lazy and acting as prima donna. I've seen very smart guys who have destroyed their career by the poor psychosocial approach of their comrade fellows. You know, you have to be collegial. You have to be a team player. You have to believe in collective intelligence. That's something that really is important. So my suggestion to my young colleague would be curious, be prepared to explore uncharted field. You know, I started my career being very good in phonocardiography and mechanogram. Look where you end up. Yeah, all these things disappear. So you have to be curious. And then you do that in your own country, but take the challenge to go abroad. It doesn't matter whether, it could be even in China. I mean, to have a contact with another culture, another way to work, will make you a more flexible individual. Get out of your zone of comfort and don't fall asleep in routine. So my last sentence to all of them, when they have their PhD, etc., I keep telling them, if the future is unrealistic, it will remain the future. If the future is realistic, it will soon become the past. And that's really a good motto in life. If you don't achieve your goal, keep working on that. And we know many, many people who did that. I mean, I'm thinking about Alain Crea. I mean, we did aortic valvuloplasty in '86. He came in Rotterdam. That was patient number 22 in the world. And then both we realized we were disappointed by the long-term result. They all reached the nose. I quit the field in 1986. He keep working, perseverance, and look what he has achieved. Is the Grunzig of the structural. I think that's the best compliment that we can give to Alain Crea.
Wonderful words. I'm sure everyone is listening very carefully to your words of wisdom, Patrick. A final question, and then I'll pass to Filippo, if that's okay. Your interests out with interventional cardiology. What can you give us some insights into? Do you have interests in sport or reading or out with cardiology?
Yeah, I
maybe
think,
the hardest question.
yeah, that's a hard question. You know, at the beginning of the interview, you asked me why I start medicine. Yeah, and I told you about the story of philosophy. Of course, I did not reject philosophy. I did not pursue because I had a very existentialist vision of life, and it was boring to memorize all the what Thomas d'Aquin has done, etc., etc. I was also very much attracted by a Jesuit, which is Théard de Chardin. I mean, nobody knows the name today, who has this extraordinary vision that God is the connection about all the conscience. And the Pope was not very pleased about that in Rome, so he had a hard time with the Pope. But if you look the world together, I'm sure that it will not take too long that all your conscience get connected. I mean, the way, if you look yourself over the last 10 years, 20 years, and in this COVID time, I mean, there will be a time we will have an hologram in front of us, etc. So I think that the connection of all these conscience is becoming phenomenal. It will take a few more centuries, but I'm sure at one point we will have a chips implanted and you don't have to read in my mind, or you read in my mind through the chips. So philosophy is there. I like
very interesting.
I like ski and tennis, but nothing special, and scuba diving. I think the most important things is the family. The family is something, I don't know in your experience, but in my experience, we all have in our professional career up and down. And what do we do then? We go back to our wife, the kids, the small kids, etc. So family is for me the hobby. Yeah.
Thank you for that. Filippo.
Patrick, I have a last short question for you. Any suggestion for the EHJ dialogues like today?
Oh, yeah, that's a good question. Okay. May I be honest, completely honest?
Absolutely.
Yeah. This is my first experience, maybe the last one, but it was very pleasant. But I think that my suggestion for the EHJ dialogue is, of course, as a topic, what is the next topic? I think the next topic I would like to hear about interaction, genomic and non-invasive imaging, what I call in my jargon, imagomics, I think that imagomics is also a term that Jean Bonwell used. Maybe he has forgotten, but after a few glasses of wine, we were talking about imagomics. The point is that once you know that an individual will develop the phenotype, you have to see if he's going to develop the phenotype and then catch that moment. So I think that's important. Technically speaking, I don't know, but an audience in the 21st century, I don't think they listen more than 3 minutes, even to Socratic figures. I'm watching all these view medi. If they don't show pictures, a graphic, a cartoon, an image, I lost interest after some time. So the Socratic person might be very, very charismatic, but I think it's difficult to listen to somebody without the support of the dialogue. And finally, don't forget that Socrates did not hide anything. Zero. Everything was written by Plato. It's Plato who has put in writing the philosophy and the wisdom of Socrates. So I suggest that the European Heart Journal should be the Plato of this dialogue in putting them in writing. What about that?
Thank you, Patrick. This concludes our dialogue. Thank you for your suggestions. Thank you for sharing with us your life and your wisdom. Thank you for putting emphasis on teamwork. I fully agree with you. Makes life more pleasant and more useful. Thank you for quoting Paul Huguenot, this giant of cardiology, and his approach to life. Everything is possible. Where there is a will, there is a way. This is something to remember in our life. So this brings to the end this dialogue. We will, of course, in the future, implement your suggestions. I am asking all the hosts, all the guests about suggestions for the dialogues, and this means that our hope is to further improve this initiative of the European Heart Journal. Everything in life can be improved and should be improved. Now, I have the announcement for the next dialogue, which as usual will be on the last Thursday of every month. So next dialogue will be on February 25th at 17 CET.